Hey everybody, I'm Dr. Deed Harrison. I am president of Chiropractic BioPhysics Seminars and Technique and also president of Chiropractic BioPhysics nonprofit, a spine research foundation. If you've been following our video series, you know that we've been doing video reviews of our CBP nonprofit research publications. I know it's difficult to read the papers, however, I still think you need to do it. But in lieu of that, what I've been doing is going through each one of our publications from past to present in a video review format using a PowerPoint presentation. Now, I took a couple months off at the end of the year, so I know that many of you have been waiting for the next one in the series. The last one we did was in mid-October, but I needed a little bit of a break. It's now January 6th, it's 2016. Happy New Year to everybody. We're ready to continue going with our CBP nonprofit research video reviews. CBP nonprofit has published spine research from a conservative care point of view starting in 1993. We've published over 150 publications, so we've still got a lot of work to do. This one is our 26th video presentation, so we've got at least 2.5 more years to go in this process. So this week, without further ado, we're going to dive into one of our case reports. I chose a case report this week because I've been focusing on some of the biomechanics studies that we've done, and sometimes we lose insight into what this really translates to and what this really means to a patient. So what I did is I chose a case study to go through for this week's video research presentation. This one was spearheaded by my good friend and CBP certified chiropractor, Dr. Tony Bistecki. Dr. Tony Bistecki did his advanced training in CBP and did his case report way back in 2004. So this paper is approximately 12 years old. However, it's still a great case. We can learn a lot from it, and it still is a very, very important subject to address. This particular case report deals with a child with attention deficit hyperactivity disorder. And there's many kids out there that are challenged by this disorder. And there's many parents and teachers that are obviously challenged by this disorder. I'm not here to tell you that every one of them can be, assisted with proper corrective chiropractic care, but I'm telling you there's a chance. When you see this case and follow me through this, you'll see that this is a wow factor. Sometimes amazing things happen, and while we don't know the mechanism, we do know that it's more than coincidental. Okay, so let's get started with this publication. It's from 2004 in the Journal of Manipulative and Physiological Therapeutics. This is the #1 journal in chiropractic today. Cervical kyphosis is a possible link to attention deficit hyperactivity disorder by my good friend Anthony Bistecki, myself, and then my other good friend and CBP instructor, Dr. Jason Haas. This was published in JMPT 2004, volume 27, E for online, page 14 is where it starts. Before I dive into the case, I want to give you a background, introduction and background. Now, because this is a child, and because there's some birth trauma that may relate to this case and condition of ADHD, I want to give you a little insight and background. We're going to primarily talk about the cervical curve or cervical lordosis in a child. So the first question is, at what age does the cervical curve develop? Now, I can tell you when I graduated chiropractic college in the mid-1990s, the school of thought was still that the cervical curve is not present in utero. It develops post-birth while the baby is crawling and lifting the head up. So there was this thought that the fetal flexed neck position was the posture in the womb where I have a natural cervical kyphosis. That's not true. It's absolutely not true. Still today, there's some people that believe and teach and promote that we have a cervical kyphosis in utero. Absolutely not true. 1977, out of the Journal of Anatomy, Bagnall et al. Published a groundbreaking study. These are 195 fetuses obtained from hysterotomies. And what they did is they fixed these fetuses in formalin, and then they x-rayed them and analyzed the cervical posture and cervical curve. What they found was quite striking. What they found was the vast majority of these fetuses between 8 and 23 weeks conceptual age had a well-defined cervical lordotic curve. In fact, they demonstrated it as a piece of a circle, by the way. So Bagnall et al., 1977, Journal of Anatomy. Here's what they identified. 83% of these fetuses had a well-defined cervical curve. It's natural development in utero. As the baby starts moving around and working the cervical extensor muscles, it pulls the cervical curve in. There's very important anatomical parameters and physiological parameters that are developing at the same time this cervical curve comes in. Now, 11% of these fetuses were straight and 6% were in the typical, quote, flexed neck posture. However, if you read the paper, Bagnall et al. Says that's abnormal. That 6%, they are supposed to develop into a lordotic curve, okay? By birth, all the fetuses should have a well-defined cervical curve is what they say, okay? So we know, number one, we are supposed to be born with a cervical lordosis. If you don't believe that, pick up any fetal ultrasound textbook today and you can see images like this. Now this one, whoops, there's a typo, it's not months, I'm sorry. This is 20 weeks. This is from a good friend of mine where he's excited. He's got an ultrasound of his baby boy that's about 21, 22 weeks conceptual age, still inside the womb. What do you notice? Well, if you look carefully, there's a well-defined cervical lordotic curve in there. So he sent me to this and he said, hey, Dr. D, check this out. You're absolutely right. My kid has a cervical curve. And I said, hey, that's the way it's supposed to do, or supposed to develop. So we know the curve develops before birth. Now, it might accentuate after birth, but it develops in utero, so we're supposed to be born with it. Anatomy dictates it. Now, here's my son. This is my son at 6 months, years of age, my oldest son, Aiden. You can see we've got a nice cervical lordotic curvature in there. This is a 6-month-old child. Okay, so this is Aiden. My child has a well-defined cervical curve. It's supposed to be that way. It's part of our human physiological development. It's needed for proper biomechanics as well. So, when we look at pediatric evolution of the cervical curve, we do see an interesting trend. What we see is up to about 2 years of age, there's kind of a paucity of information on it because there's not too many X-ray studies on kids under 2 years of age. We already know from what I just covered, the Bagnall study, 1977, and if you look at just proper fetal ultrasound textbooks, you'll see the cervical curve develops in utero. Well, when do we really see a evidence-based analysis of curves in kids? Well, one of the first reports that we could start to look at the cervical curve came out in Spine in 1996 by Kasai et al. Now, Kasai et al. 1996, they looked at 20 kids in different age groups. So 20 in each age group. 22-year-olds, 23-year-olds, 24-year-olds, and 25-year-olds, etc. I'm going to stop at 5 years of age. If you do a simple analysis of what we call exchange of one radiographic analysis method to another one, the way CBP doctors are trained to mark the cervical curve, it's called the posterior body tangent method. The way the Kasai et al. Study did it was they used a Cobb angle. So we have to use an equation to convert the two data sets so they match, and that's what I did in this table here. A 5-year-old is supposed to have roughly a 27 to a 28 degree cervical lordosis as measured with the posterior body tangent methods. Now, if you go to the Kasai paper 1996 Spine, you will not see that number reported. You will see a different number. So what I did is I extrapolated using an equation that's validated, and I converted the two data sets to match. Okay, so we're supposed to have a well-defined cervical curve in a 5-year-old child. What happens to a child if we don't have a cervical lordosis? Well, any number of things could happen and maybe nothing happens. However, some interesting papers do exist. This one might be one of the most profound. This one comes from a Scandinavian journal out of the peer-reviewed literature from Acta Anatomia. Okay, Acta Anatomia, or excuse me, Anatomia Clinica, sorry. This particular paper looks at what happens to the airflow or the sphincters in the throat and the nasal passage, what happens to their magnitude, what happens to their diameters, their cross-sectional area, when you have a cervical curve versus not having a cervical curve. So this is an anatomical study. This is not an opinion paper. This is taking samples of kids or fetuses and looking at what happens when we have a curve and we don't have a curve. Okay, so this particular paper, Acta Anatomia, I got it right the first time. It wasn't Anatomia Clinica. Sorry, read too many papers sometimes. 1994, volume 149, page 141 through 145 by Schatz et al. Cervical posture and nasal breathing in infancy. Here's what they identified in their conclusion, and I'll show you some of their actual data. The most important anatomical parameter, this is a quote, found to facilitate the switch from nasal to oral ventilation in human infants is a cervical extension, creating a physiological lordosis of the neck that results in an opening of the veloglossal and the veloepiglottic sphincters. Here's a cross section. This is the veloepiglottic sphincter right here. When you lose your neck curve in infancy, when you're a baby, in childhood, it shuts down the airway. It closes it down. Okay, you look at this. This is the veloepiglottic sphincter. It's closed right here because you do not have a normal neck curve in this infant. Contrast that with, this is a natural cervical curve. It opens up the airway. Now, you can understand the potential ramifications of this. Number one, in milder cases, you'll get a subtle hypoxia. You're not able to respirate as efficiently. It takes more energy and effort to respire. Also, then it creates a subtle hypoxic or lack of oxygen situation. We can get things in the brain called ischemic penumbra. Ischemic penumbra is a well-known phenomenon where we get a subtle change in blood flow to brain neurons and they subtly shut down or hibernate. They don't die, they go into a low energy state. They hibernate. It's called ischemic penumbra or cerebral hibernation theory. Look it up. I'm not making it up. Okay? You look at this in an extreme case, things like sudden infant death syndrome may be related to this. If you read the paper, these are the things you might understand or see from this particular project. Now, back to our case. If I have a cervical reversed area in a child, it could be subtly shutting down the airway just like this anatomical paper shows. It could create a state of hypoxia. It could then alter the way brain neurons coordinate and control activities, including thought and behavior. Okay? Now, you might say, well, Dr. Deed, you're making this up. No, it's not a leap of logic. It's actually a linear process. There's a connection here. It's not 100% clear, but I'll tell you right now, there's a connection here. We do know this. Birth trauma in hypoxic states have led to ADHD cases. We do know in very difficult labors, we know when a fetus aspirates amniotic fluid, we know that we can get a state of hypoxia in the brain, and we know that this has been correlated in several studies to ADHD and behavioral issues. This is no joke. It's related together. If you read the paper that I'm going to go through and you read some of the literature, this is the connection you will see. So back to our particular case. This is a 5-year-old child that comes into Dr. Tony Bistecchi's office. He's been diagnosed with ADHD for the past 3 years. So since the kid was just over 2, this young boy has had behavioral issues. The parents, the daycare, and the pediatrician have all concurred and said this is an ADHD case. The ADHD checklist was followed by the pediatrician, followed through with the parents, followed through with the teachers. It's a comprehensive diagnosis. Now, this kid has had behavioral issues, outbursts, inability to pay attention in social environments like church and at school, etc. Now, what do they do with these kids? Well, they put them on drugs. They put them on drugs. That's just the plain, simple truth. They put them on Ritalin, they put them on Haldol and Adderall. Okay, so from WebMD, I've pulled up this medication chart just to show you what the actions are and what the side effects are of some of these drugs. Adderall and Haldol and Ritalin. That's what this kid has been on for the past 3 years since he was 2 years old. He's a 5-year-old. So look at this. You look at this, Adderall. Okay, number one, it's a short-acting medication. It lasts 4 to 6 hours. It's a stimulant. Look what it causes as known side effects. Not guessed side effects, known side effects from the drug manufacturers themselves. Some loss of appetite, weight loss, sleep problems, irritability, tics in the body and the face. This is important because this child has facial tics, like a type of neurologic drug-induced Tourette's syndrome. Okay? These short-acting medications require frequent dosing. Okay? So then you go down to Ritalin. Okay? Some loss of appetite, weight loss, sleep problems, irritability, tics, etc. Some of the problems this kid has can actually be caused by the medications. So it's like, what do you do as a parent? What do you do? I'm not here to tell you not to take the medications. What I'm here to tell you to do is maybe you want to seek additional advice about other things that can be done in addition to the medications. Or if you're that type of parent, maybe you just opt for the conservative care route to begin with. Okay, like diet, effective discipline, and let's fix the child's spine and the neck and make sure the nervous system works properly. Okay? Here's the deal. This kid is unsuccessfully treated for 3 years, still on the medication. He's got inattention, disruptive behaviors, failure to complete simple tasks, forgetfulness, facial tics. Okay? We don't know if that's medication induced or not. Inappropriate outbursts at school and at church. Okay? And here's the WebMD link for this if you want to look it up. History and exam. We do have a history of a prolonged and difficult labor in this child. The child did aspirate amniotic fluid. So bang, we've already got a pre-existing hypoxic state in this child. Now, in a difficult labor, when they use forceps or the vacuum distraction or somebody pulls on the head and neck as the child's coming out of the birth canal, this can potentially create a problem where we damage the upper cervical spine, maybe straighten out the cervical curve that should be present, right? So one of the things we want to do is assess this child's neck for proper movement and proper feel. This is what chiropractors do. So what was found is there's spasm in the neck muscles in the back, the posterior neck muscles, from the base of the skull down to the upper thoracic or the top of the shoulder region. Okay? There's a reduction in all ranges of motion. This kid does not have normal range of motion for a 5-year-old. Kids are supposed to be able to move like Gumby. They move, this kid can't. Also, it's painful in his upper neck from the skull to C1. When Dr. Tony Bistecki was palpating and putting some pressure, the kid was saying, hey, that hurts, right? Jumping off the table. So now we've got some issues that we've got dysfunction in the neck. Let's identify a potential cause of that dysfunction. Let's take an X-ray. Lo and behold, we see an X-ray. This is the child's lateral cervical view. So what you're looking at is the side view. Here's the teeth. You can see the molars. You can see the teeth in the jaw. Here's the top of the neck called C1. Here's the skull. You can see there's no curve. It's a reversed cervical curve in this child. The upper neck is slightly kyphotic. Could that close down the veloepiglottic sphincter? Yeah, it can. Could that change airflow into this child? Yeah. Could it cause a subtle hypoxic state in the brain and the nervous system? Yes, it can. These are possible mechanisms. I'm not saying it's the only one or it's absolutely what's going on, but these are probable likely scenarios. This is what we see. You see bones on an X-ray, we see more than that. We see altered anatomy, altered physiology, altered function. The child is manifesting this as ADHD. Okay? What else do we see? Postural problems. Right lateral head translation in the child. His head is shifted over to the right and it's stuck like that. And then forward head translation. These are two of the primary postures that were identified. What do we do about it? Now, this is not the child and this is not Dr. Bistecki. What I'm doing is I'm showing my child. My child was 6 years old here. And we're showing what we do as sample adjustments here. So this was my oldest who I showed you his X-ray with. This is what we do to reestablish a curve in a 5, 6, 7-year-old child. They lay face down prone on their stomach. We put them in mild extension of the head and neck with some mild backwards shifting or translation because the head was forward. And then we put mild to moderate pressure in the neck at the apex of the cervical curve. This is not uncomfortable. It's not painful. This is very tolerable by the child. We do this all day long with children. Okay? So we are thrusting into the neck to reestablish the cervical curve. It's called a chiropractic biophysics corrective adjustment for the cervical curve. We also can use an instrument. Now with the instrument, we can get more segmental specific than I can get with my hand. So let's say I want to contact a specific joint or specific vertebra like C4, cervical 4, or cervical 5, whatever it is. I'm going to place my instrument at that level, and then I'm going to angle it so I get in line with the plane of the joints to reestablish the cervical curve. This is one of the techniques we use, okay? So if this by hand scares you, and it should not, then we can go to an instrument technique, or people like me, we use both. Here's a sample of the patient. A sample of the patient's posture. This is not the patient. I'm showing you what we had in terms of the right head translation. Now I've covered up the face so we can't identify this individual. This is a child of similar age, and you can see here's the center of the upper back, and if you look at the face and the neck, you see a right lateral deviation or a right lateral shift. My late father, Dr. Don Harrison, called this a head translation. He was the first person to identify these types of postures and said, whoa, this is a major problem. The head is shifted over and the neck is shifted over and it's stuck like that. Could that create some problems? Could that create nervous system irritation? Yeah, certainly it can. Can it create spasm and decreased range of motion? Yes. Do we know, can it alter behavior? We don't know the answer to that one. Okay. However, we do know that the head and neck should be centered in the chest and rib cage should not be over like that. So this is an adjusting technique that we use. Okay. We put the person on the side opposite of the head shift or translation. In this case, the kid's shifted to the right. So we're going to lie him on the left, and then we gently force the head and neck, and it is force, but it's gentle force, towards the opposite side, and we apply a chiropractic thrust procedure. We will do this every visit the child comes in. This child was seen 3 to 5 times per week for 8 to 10 weeks. There are 35 total treatments that were administered in this child. Additionally, what was done? Extension traction. Now the child's 5 years old, so he's old enough to do some of these procedures. Extension traction is depicted here. Now we have pediatric versions of this now, but in '94, these are the two techniques we had for kids, okay? We had this one here without a support in the mid-neck, and then we had this one with a rubber bungee cord, if you will, with a foam pad over it so it was comfortable in the child's neck. These are the two techniques we use. This helps rehabilitate the shape of the curve over time. We're going to lay the child initially for 1 minute in these devices, and we're going to work the child up to 5 to 10 minutes per session. This is the only way you're going to truly change the neck curve routinely and consistently. It's the way the spine is set up to work biomechanically. Now today we have this thing called the pediatric Deneroll. Deneroll, D-E-N-N-E-R-O-L-L, the pediatric Deneroll. Now, this is specifically designed to rehabilitate the cervical curvature in children. We do have adult versions of this as well. We do not sell this to the general public because it requires a proper diagnosis from a licensed healthcare provider to see if you're a candidate for it. You cannot just use this device just because you think you have a loss of your neck curve. It has to be administered by somebody that knows what they're doing. It is not a toy. Okay? So the only way you can get this is through an actual licensed healthcare provider. Okay? And if you want more information on that, you can go to idealspine.com, www.idealspine.com, or you can go to Deneroll.com, Deneroll.com. But I'm going to tell you right now, as a layperson, public member, you will not be able to purchase this through any company that sells it. They won't give it out to you. It can cause harm if you use it wrong. Okay, so we do not want you using it inappropriately. It's got to be done under the supervision of your healthcare provider. Okay, that's the pediatric dental and these in-office traction devices to restore the cervical curve. Okay, the public needs to understand trained providers who you see for this. There are indications and contraindications for everything. Here's the results. 35 visits later, doing adjusting and doing the traction. Look at this. Wow. There's a beautiful cervical curve now in this child's neck. This is a near perfect cervical curve. The upper neck is beautifully aligned. The skull atlas area is beautifully aligned. We've got almost equal space between the base of the skull and the top of the atlas, and the bottom of the atlas and the top of the C2 spinous. That's where it's supposed to be. Look over here. It's too close. The atlas is too close to the skull. That's a problem. There's a beautiful cervical curve here. That's the result of treatment. Dr. Anthony Bistecki did this with the child. Okay? Now, what happened to the ADHD? ADHD behavioral problems slowly resolved. By the 27th visit, the changes were so remarkable, the facial tics were gone. The parent and the teacher both went, wow, this kid is now behaving appropriately. He had it for 3 years, and 8 to 10 weeks later of doing something new, corrective chiropractic, now we've got to change. Now you could call it coincidence, or you could call it's a result of the new treatment method. Now they sent the kid back to the pediatrician, and the pediatrician said, these results are so remarkable, I don't think he fits the checklist of ADHD anymore. And the child was taken off and weaned off the medication. That's a big deal. That's a life changer for a child. If we can get the MDs, the parents, and the chiropractors to work together to properly manage these kids in a goal to get them off the medication, that's the best thing, right? Nobody wants to be on medication for life. Now, there's a few people and a few cases that likely need that. I'm not an MD. I don't prescribe drugs. I'm just telling you my opinion on it. There's cases that need that. However, the ultimate goal in healthcare should be to wean you off these things, to get your body to heal and work right. And if we work together as a team of providers and work with the parents and we work together, we can do this. Now, chiropractors cannot diagnose and prescribe medications. We can diagnose and treat disorders, we just can't do it through medications. So we need the MDs to work together cooperatively with us. Chiropractors, we're not esoteric quacks. We've got enough cases like this to show you that we know what we're doing, and there is something going on here when we correct the neck. These cases do respond. Now, maybe not every one of them, but certainly this one did. This one was so profound that we wrote it up, and the journal thought it was such a good case. Because we've got a history, because we've got proper diagnosis, because we've got the MD and the parent and the teacher and the chiropractor all working together with this, it was published. This case potentially could change the lives of many other kids out there with ADHD. Let's think about that for a minute. Maybe you want to change their diet. Maybe you want to get them off the crap that they're eating. Maybe you want to get them more organic and holistic based foods. Maybe you want to do effective discipline, okay? Effective discipline, some structure, some guidance. And then let's check their spine. Maybe there's something going on that you're not aware of. Their spine could be so damaged, it's causing alterations in physiological function. This case exemplifies that. That's the end of the case. Hopefully you enjoyed it, and you can see I'm excited still and passionate about this in 2016. I may be a year older, but I'm not slowing down. If you're out there and you want to support corrective chiropractic research, listen to the message at the end of this presentation. Also, if you're a parent out there, then you know what? You should look at this too, and you should say, hey, I might want to try finding a corrective care chiropractor that does CBP technique. Follow the information at the end. You can find CBP trained chiropractors. Until next week, thank you very much for your time and attention. And again, happy 2016. I wish everybody a successful year with peace and prosperity. If you like this information, if you're a patient, you need to go to a Chiropractic BioPhysics trained chiropractor. You can find us all over the United States, Canada, and international locations. Go to www.cbppatient.com and look up CBP providers in your area. It's an easy-to-use, user-friendly site. search for, at first, a general or advanced trained CBP chiropractor. If you can't find one of those, then find somebody that's at least on the directory and has taken our courses and that does the work. Okay? So let's go to a CBP trained chiropractor, www.cbppatient.com. If you're a chiropractor and you're interested in this, either learning more about it or maybe it's brand new to you and this particular video research project intrigues you, come to our website for doctors. Go to idealspine.com. We've got a lot of things there for you. We've got training, we've got conferences, we've got products. Love to have you on board and become one of the CBP doctor family providers, right? We need your help. There's patients out there that need you, and if you don't get trained in this work, then you're not going to be able to provide them the type of service that we think you should be providing them from a corrective care point of view. Also, lastly, anybody out there, we also need your help to continue to do research investigations like this, right? These are time and dollar consuming projects. If you will, go to our website directly and sponsor and support Chiropractic BioPhysics nonprofit. Make a donation of any amount to us. Also, you can do it indirectly on Amazon Smile. Just select Chiropractic BioPhysics as your nonprofit foundation, and when you purchase through Amazon Smile and Amazon, CBP nonprofit will get 0.5% of all your purchases, which is a big deal. It adds.